Good afternoon or hello, whatever time of day it is for you. Welcome and thank you for joining our web series on COVID-19 and eye health again today. For those of you that don't know, I am Jude Stern, the Head of Knowledge at the IAPB, and I'm based in Sydney, Australia. And as such, I would like to acknowledge that I'm hosting on the traditional lands of the Gadigal, Bidigal and Birragul clans who traditionally occupy the Sydney coast. I would like to pay my respects to elders past, present and future and extend that respect to any Aboriginal and Torres Strait Islanders who are with us today. As we know, the coronavirus pandemic is rapidly changing the way health and development communities are working. The eye care sector, like all health sectors, have had to adapt and change their services to combat the spread of COVID-19 and ensure the safety of patients and health workers. IAPB's COVID-19 and eye health program aims to provide useful information and guidance to the eye health sector during this time. We have listened to the questions and issues being discussed in the sector and invited experts from across areas of health and development to discuss key topics that are impacting our work and provide the evidence-based best practice to help organisations adapt and inspire new ways of thinking. We're thrilled to have had over 750 people join us to date on our webinars and really looking forward to welcoming you today to this webinar. This week, we're looking at how technology is being used to continue eye care services during and post-crisis. Yesterday, we heard from Professor Tien Wong on telehealth and AI for eye care in COVID-19. If you missed that, it will be available on a recording on our website in the next few days. Today, I'm delighted to welcome Dr. R. Venkatesh, the Chief Medical Officer of Aravind Eye Hospital, and Guan Chung-Hong, who's the Senior Program Manager at Orbis International, North Asia. They want to present work they have been doing with low-cost technology and innovation that can help in the time of COVID-19 pandemic. Before we get started, a couple of housekeeping things. Just want to run through how our webinar is going to run today. Firstly, we'll have Venki's presentation and Q&A, and then we'll move to Guan's presentation and her Q&A. So I encourage you during the presentations, as you think of questions, please type them in the Q&A box, and I will ask the questions to the speakers at the end of their respective presentations. And we'll try and get through as many questions as time permits. If you have any issues with the audio settings, please see the audio settings icon on the left-hand side of your taskbar and adjust the sound if needed. For the best quality sound, you'll find that you'll get the best quality sound on headphones. I'd also like to acknowledge the amazing team that we have here at IAPB, in particular Rachel and Teja, who are supporting the webinar today. They are comms and logistics support for this webinar, and I really want to thank them for the efforts that they have put in. You probably noticed the webinar is being streamed live on Facebook, and we recommend that we encourage you to connect and share via Facebook Live and Twitter during the webinar and afterwards. This webinar in particular has been supported by the IAPB Valued Supplier Scheme. The Valued Supplier Scheme provides specialist products and services that save members time and money. The suppliers offer exceptional value and outstanding quality, and you can find the supplier scheme at the web address that is listed below. Okay, so today, first up, we have Dr. R. Venkatesh, or Venki, as he's known to most of us. He's the Chief Medical Officer at Aravind Eye Hospital, and I've had the pleasure of working with him on planning the GA, which has been postponed, but we've been planning that together over the last year. Venki's been a consultant at Aravind for more than 20 years with a special focus on cataract, microsurgery and glaucoma, and has a great presentation for us on innovations at Aravind. Welcome, Venki.
Thank you, Jude, for the kind introduction. In the next 12-15 minutes, I'm going to share some of the ideas which have come up during this period, where we are all going through a crisis of this COVID-19 pandemic, and how we have changed our practice so that both our staff and also the patients who come to the hospital feel much comfortable and safer. So briefly about Aravind. Aravind as a system has got several eye hospitals, including tertiary care centers. On an average, we see close to 13,000 outpatients a day and we do close to 1,500 surgeries. We do a lot of outreach eye camps, which most of you know. And also we teach a lot of residents and also ophthalmic technicians and people who administrate eye hospitals extensively on a daily basis. So what happened after the mid-March, somewhere between March 15 to 20th, when this pandemic reached India, this is what happened. So now on a daily basis, only the 7 tertiary care centers are running. All the other centers have been closed down because of the lockdown regulations in this part of the country. And we are just opening up few of the secondary care centers now. We see close to 1,500 outpatients, which is like 10-15% of what we normally do. And we are doing 75 surgeries, which is again like less than 5% of normal work. All our eye camps and outreach activities have been suspended, again, according to government regulations. And we are doing a lot of online classes for our residents and technicians to maintain social distancing. The important thing is when the lockdown started, the hospitals were supposed to be kept open, but totally there was no transport. So people even with emergency were not able to come unless they had their own transport to come. And also there was a break in the supply chain. Most of the shops were shut down, so we were not able to buy anything. And at the same time, we had to make sure we bring that safety in this period of COVID crisis. And also, we didn't want to compromise on patient care because the people who were coming at this point of time had real emergency, maybe corneal tears, lens-induced glaucomas, people with trauma, and several other issues like vein occlusion, arterial occlusion. So we had to continue to give the care, but in a very safe atmosphere for both patients and the staff. And we all know, I don't want to go in detail, how a lot of these touch points, there are a lot of theories running around in social media that all this can be there for several hours to several days sometimes. So we need to be very careful in this kind of transmission. And also we know that coughing and sneezing, definitely yes, but even talking, there's a better understanding that even by talking, these micro droplets are there in the air, which is again very, very significant in eye care, because in eye care, people go very close to the patient when viewing on a slit lamp or doing several tests like OCT, ultrasound. So you need to be very close to the patient. So we have to keep all this in mind so that the disease the virus doesn't pass from patient to the doctor, and also from the doctor to the patient. Any one of us can be even an asymptomatic carrier at this point of time. So like what Winston Churchill said, never let any good crisis go waste. So we also from day one, we thought we should make this crisis into an opportunity. And we worked on several ideas, which some of them turned into innovations, and now it is being even proven kind of cost effective in this period of 7 to 8 weeks. But at this point, I would have to have a disclaimer saying that these are all ideas which are being practiced in our system, but some of them can be kind of taken, like how Arvind Model has shared several other ideas. Some of this can also be practiced elsewhere to make their own clinics or hospitals safer. So I'm just classifying these ideas or innovations into 3: social distancing innovation, hand hygiene innovation, and personal protective equipment, because these are the 3 mantras which people are asking us to follow. We have to maintain social distancing. We have to make sure we have a good hand hygiene so that we don't touch anywhere. And then using masks or face shields in healthcare is so important. So let's look at some of the social distancing innovation, starting from like we had to do from right from day one. We had to remove or close all the entrance and make sure we had only one entrance, which we have for the outpatients. The inpatients, the charitable entrance were all closed. All air conditioned systems were closed because people believe inside an air conditioned area there's a lot of virus circulation. But fortunately, we have ventilated rooms with partial air conditions wherever we need, so that we are able to do this. We removed all the curtains. We kept all the doors open so that there won't be any touch. And any unassigned area where patients or staff need not go, we closed it down. The second thing is we had to create a new area to triage the patients. From the entrance, we had to maintain whatever the guidelines now, the national, international guidelines, from temperature monitoring to making sure they fill up a COVID consent form, no, regarding travel history, which is again redundant now, but it's so important to know about the patient and whether anybody in that home have any of those symptoms of viral infection. So all these are done in the entrance, and then we have kind of created a clinic for basically conjunctivitis. So there's a lot of evidence now that COVID also relates to conjunctivitis in at least some evidences which have been coming up from Singapore, China, and also from Europe now. So conjunctivitis is another panic. It's a seasonal conjunctivitis we get, adenoviral, but there is a panic. So we had to create this safe cabin to do the quick conjunctivitis examination. So this is like a red eye clinic, which functions at the right at the entrance. You can see a nice ventilated window. There's a door on the other side. There's good cross ventilation. We've kept a fan also here. And also this is totally airtight, covered like a plastic cabin. And you just saw a video of how this slit lamp can be safely fitted so that the chin rest is outside, which is cleaned meticulously in between patients. And the doctor with full PPE is there inside so that he may not come in contact with the patients. You're just seeing a view of how this cabin is. So it's covered on all three sides, and there is a nice ventilation from the back. And whenever there is a need for a fan, they would add on to it. And we also put an ultraviolet light here so that this area is also decontaminated at the end of the day. So we had to modify the whole way we examine. So these are things which we did, and we are encouraging everyone to do that, to bring their vision optometry units outside the closed areas, so that again you have nice ventilation for them. The light may be a hindrance, but we can overcome by using technology like autorefractometer or other facilities which we have, so that they are in a place where it's very safe. Their droplets can quickly move off from that atmosphere wherever they are. So we had to bring some of the clinics outside into a well-ventilated space, and we had to give all the personal protective equipments to people who are coming in close contact with patients. So you're just seeing a video shot. This is basically a lobby which we use for registration. The new and review registrations are here. People used to wait in this lobby, but now we have converted this lobby into a triage area where almost 50% of patients are disposed. As we talk today, we are seeing close to 400 outpatients today, and almost 200 to 250 patients can be disposed or can be sent home without compromising the quality within an hour, so that the chair time with the hospital, the chair time with the doctors is also significantly reduced. So you see the layout which is here. So there is a vision, there is an optometrist, and there are doctors' examination cabins, and these are all the social distancing activities which are happening in the registration area, so they don't go close to the patient. And we also found that there is a significant time involved in doing the 90 diopter or whatever examination they do with the fundus, and there is also a close contact to the face, and we know that tears can also transmit this virus, so we need to be careful. So what we developed is, we are now experimenting it to see whether a fundus photo could help, and how do we do that safely so that a technician is inside the cabin and the patient is outside, so that we can clean the bush or whatever comes in contact with the patient meticulously after every patient. At the same time, can we do a non-mydriatic fundus image and then upload it into the electronic medical record, so that we can save the chair time and the dilatation time, and also the contact time of the patients with the treating physician. So they show the ID card and then the non-mid. So this is a fundus on phone. It's by a company called Remedio, which is based in Bangalore. We use it extensively in our outreach. So it's very simple. It's an iPhone-based camera where you can take brilliant images of the posterior pole, even when the pupil is roughly like 2.5, 2.6 millimeters, and then you upload those images, and then the doctor can see on the EMR, so that then you can avoid that contact and you can maintain a social distancing. So this idea again started, actually it came from one of our residents. Like most of the time they are spending in taking history of the patient. So can we do a social distancing history? So we decided that we'll put couple of residents here, and then the patients are waiting here. So they call them and take the history. So history took almost 50% of the time. Now, how many years diabetes, hypertension, what drug, and things like that. So now they are taking this history before they come to the triage doctors. So the 50% chair time was reduced. And this is one simple idea, no, which is, I think we are going to even practice for a longer period in our system. But the important thing is we need to educate the patient before that. They will be calling them on phone to get the history so that they don't feel anything subnormal about that. The other thing is more like a behavioral change. So we used to do like this, like many of the hospitals did. We had some crosses and things like that. But at the end of the day, people used to keep their handbags or X-rays or some CT scan reports. So we have to keep on cleaning those chairs. So we decided that no, we would remove the central chair. It's very easy in some of these chairs where it can be just dismantled and then kept safely, so that automatically you have a social distancing and people can't leave the bags anywhere other than with them. So all these are small points, but make a big difference in high volume practice like in our system. The second, I'll quickly go to some of the hand hygiene practices, which are very important. Normally, you do hand rub in between some procedures, but the habit of washing and all that is not there when somebody comes to an eye hospital or a facility like this. So we had wash basins, and we found that people were using a lot of soap and water, because again, water is a scarcity in summer in this part of the country. So we came up with this, again, a very simple idea of having a foot control, with a small shower here. So significantly it reduced the time they wash, and also the water which is used, because after they put soap only they go for washing. So this has now become a part of the system. I think this is also going to stay longer, like how you see here. And the other thing is with our staff, they normally, again, you have a lot of touches like this when you're using a hand rub. So at this point of time, we were able to not source any foot pedal auto dispensers, because all these touch-free ones, totally there was no supply chain. People were not able to buy. People are not able to order on Amazon, or on other online things. So we developed our own way of dispensing sanitizer with a foot control. So our maintenance team worked. They saw some videos online, and they came up with an idea where there is no spring and it's totally maintenance free. So now we have shared this idea, and a lot of people started making their own. So all this helped in the last 8 weeks, but now there are so many dispensers for this, but many of them are expensive, electronically controlled, and also they may fuse out or not work after some point of time. So the last point I would cover is something related to innovation, related to personal protective equipment, which are very important. Again, 8 weeks back when the lockdown started, we didn't know how to get a face shield also. So we quickly figured a way of doing with simple OHP sheets. A lot of people do different designs, but our design is very popular. Again, it's again a double-side tape, which is put to the sponge, and then you measure the elastic band, and then you put this sponge to the OHP sheet. So that becomes like your nice headrest. And then you put the elastic band on either side with a stapler, and your face shield is ready. So we started using this from as early as March 20th, I would say. The 22nd lockdown started, but even before, a couple of days before, we started using this face shield for our patients. For our staff, either from our security to everybody. Now there are several face shields in the market which are available. Aurolab makes face shield for us now, and we have a constant supply. And this is one small packing material. Now we made some place so that this can be stored safely, and the names are written at the end of the day. And also this is decontaminated using UV light. So at some point, seeing the demand for the N95 mask, we also have a 3D printer, and we got open source to print the 3D printer, and we sketched some 10 or 20 of them ready. So once there is a demand for the N95 mask in the operating room, we can get the filter, N95 filter, which is available, and then we can start using these 3D printed masks if there is going to be a growing demand, as we see in other parts of the world, especially in US and in Europe. And also we have a model for 3D printed shield. At this point of time, we are not doing it because we already have some low-cost shields available from Aurolab. The slit lamp shield, which is very popular from from the practice in China, everybody started having shields. So there are different shields available, but we put a simple idea of putting a sticker on either side so that the patients can focus. They can't see the ear, but they can see a blue color or yellow color on either side so that your examination becomes comfortable. And the last one, before I finish, we all know there's a big demand for the mask, especially the N95 masks and the respirators. And there is a good guidelines now from CDC saying that you have to reduce the number of staff who are going to really use the PPE, use alternative respirators, and also you find a way to extend or reuse. So a lot of evidence have been coming up using ultraviolet light for decontamination of the mask. And there's a couple of studies which are already published, one from Nebraska Medical Center, where they have these UV lights and then they hang the mask around it. So what we did was we got an idea of changing a freezer box, which is usually stored ice creams and some of the cold dishes. So this is a cold storage because it's airtight closure you get. It's a condemned box, which was sourced from a guy who repairs all those things. It was just lying outside in a shop. We sourced this, we cleaned this, we tried this, and then we put UV lights and also we added mirrors to it. We did some study on this. We asked people who work on UV lights. The mirror reflects the light so that you get a very good concentration of UV light so that you don't have to put it for a long hours of time. So you can save electricity. So these are the respirators which we have given to the doctors. They are collected and then you can see these respirators are gently hung inside the UV freezer box. These are the mirrors which are here, which reflects the UV light, and the light is on the door. And once you close the door, automatically the light switches on. Once you open the door, the light switches off. So it brings safety also. And once the UV sterilization is done, the doctor's name is there. They put it inside the pouch and then keep it ready for the use next day. So a team of people, like how they do central sterilization of OT instruments and other things, now a team does this, and we also have a plan for that. We didn't stop there. We had a series called Jugaad series. Jugaad in Hindi means where you bring cost-effective ideas where there are resources are not available. So there are a lot of ideas like this shared on WhatsApp and Facebook. We thought, why don't we have a competition? With the support of Aurolab, we had a nice competition and we had a finals last Saturday. We had some brilliant ideas coming up, and then we shared that widely in our YouTube channel, AuroTube, and also in our Facebook page. And then the recordings are available for people to see and start using some of this for their safe practice. So at this point of time, again, the disclaimer is we don't know how effective it is, but every day there are new evidences coming, new publications coming, new ideas coming. We are just trying to see how to make our place safe so that our staff and the patients at the end of the day feel comfortable working with us. Thank you.
Thanks, Venki. I love the ingenuity of so many of the innovations that have come up, and the fact that you decide to take a break, but your whole team has worked tirelessly during this time with our patients to actually try and improve the service for patients when they come back, which is, I think a lot of what the sector is doing broadly, and it's very commendable.
The point is, now a lot of people have more and more evidence on shields and how mask is protecting. But when the pandemic started in India, like in March 2nd week, we had no idea.
Yeah.
So the first thing we did is we had a call with the team in Singapore National Eye Center and also with the IR group in China. And then we discussed with them what all they did. And we started some of the practices from day one, because most of the clinics were closed, hospitals were closed. So people didn't know where to go for eye care. They only have to go to tertiary care centers and institutes like that. So we were not able to stop our patient load. So we had to think of ideas and solutions from outside, but we were not able to source it. No, we were not able to buy it or source it, because all the shops were closed, no online sales, nothing was there, no movement. So whatever available resources we did, and some of them are so exciting and so good, they're going to even continue for a longer period. And some now, after a certain period, we started getting from other sources which are less expensive than what we can make.
Yeah, I think it's, I mean, it's fabulous. But my one question was, so before I speak, just anyone that has any questions, please type them into the question and answer box now for Venki, and I can ask a few of them. But, you know, you've got so many great ideas that came out. How do you encourage your team, but also how do you assess the innovative ideas to know that they're going to be safe or the most useful or most impactful ones?
That's a good question. So what we did is, in a week, we realized that we are going to a new normal. So we need people who are going to rigorously monitor some of these new normals and take it forward. As Institute, we had quality audits, for audit accreditation process. So we had a quality office. So we made that into a COVID task force office. So any new thing we changed. For example, history taking, we asked the team to evaluate the effect of it. They were rigorously following because we had more than enough manpower, right? So because of the lockdown, patients were less. So we were able to give them the required manpower and do a light of auditing, sitting in their office or at home, and then telling us within 60 minutes how many patients we were able to send today, with this staff available, or within 180 minutes. So we were able to see a significant reduction in chair time. So once we know that within this 2-3 days, this pilot work, the history taking work, we took it to next level. We give them speakerphones. We made that a system. We had some coaching for them. So like this, everything was pilot tested quickly. So sometimes we take our own time to test it. Even there are some ideas we take our own time. But in this time, we understood this crisis, we have to change every day. So some of these pilots took quickly. Some of the ideas like water, the foot pedal control. So the maintenance team kept working. They were seeing some of YouTube videos, which are available from several years back, how people did that. And then they came up with their own ideas of the material available with them. And in fact, interestingly, we had to even go sometimes to some of the patients had electrical and hardware shops. So we had to go to the back door and get things. So that was the best part.
That's good thing to draw on your own community, right?
Yeah. So we had to misuse our ambulance at some point, like ambulance is meant for emergency. So if you send an ambulance, even in a lockdown, they allowed an ambulance. So we sent an ambulance to collect plumbing material, to collect an UV light, but it's also important. It's going to give patient care. So we had to discuss with the police that we are going to bring this light or bring this. Then they also gave us permission. So a lot of interesting things happening and a lot of learnings also from this crisis.
Absolutely. And I think a key thing, because people, want to introduce these new things and they don't necessarily have the scale and capacity that you do, but that, any new introduction is incremental. You test it, you make sure that it's, working in your setting, and then you move forward.
In fact, today, Jude, we had a very critical discussion to see whether we should take that fundus imaging, because people are not very comfortable. In the meaning, in spite of imaging, the image was not clear. They continued to do an 90D. So 2 doctors or 2 residents and 1 senior consultant did a very detailed auditing, and they just did the presentation today morning at 10 o'clock. And we are going to take a call whether to continue that idea or not. So 2 audits were done today. One is on phone and the other one is on fundus imaging. And we feel now that fundus imaging is only kind of creating a bottleneck now. When the OP was less, it was fine. But now people are just waiting for the fundus image to come. So that increases the time of the patient in the hospital. In the last, at least from May 1st, when the OPD started increasing after the lockdown leased. Now we are from 3 to 4, lockdown 4 we call. So now we are trying to reverse back or not, maybe try to see whether we can increase the number of fundus cameras or maybe stop that and allow them to do a 90D.
Yeah. So I'm just going to try and whip through a couple of questions. We've had a few come in here. I could keep asking you about that, and you can provide us updates. Perhaps we can post them in post-webinar about how the audits are going. This should be a relatively straightforward one. Do you use any footwear protection for patients and staff?
Not actually, no, because there is so much of movement. It's not like a small clinic where there are 10, 20 people. We can ask them to remove the footwear and give them an alternate footwear. But practically, it is not possible. So we are only following the general guidelines of mopping the floor every couple of hours, and where the footfall is more every hour with Lysol solution. So that's the only thing which is happening. But we are thinking of some ideas where it could decontaminate your shoes or your slippers without removing it, within 30 seconds or 1 minute. If they can stand somewhere, we are looking for ideas like that. If somebody has got ideas, we are ready to
please send them in.
that.
Yeah, share. So we have a question here. Your innovations are really commendable. What are some of the challenges you have faced in implementing these innovations, and how have you overcome them, if any?
So one basic challenge is the limited, as I was telling you, because of lockdown, getting material was a challenge. But when we think of challenges, it's only about how team wants to adapt to it. That's what the normal challenge anywhere is. But mostly in a system like Arvind, the not-for-profit organization, that challenge is not a big challenge. In the meaning, people are always looking at incremental innovation, and they quickly change if it is going to make a difference in the patient care, either in the quality or safety. Either be removing the central chair. If I say this is going to make a difference, it will be done in a couple of hours. Nobody is going to challenge saying that should we remove this? Where do we store it? No, let's find a way to store it. But if it is going to make a change in the safety or in the quality, the acceptance to it is very good in systems like in Arvind.
Yeah, great. I'm going to take 2 more questions, and then if there's time, we'll take more at the end after Guan's presentation. There's a question here about what about the refraction and dispensing services? What special things are you doing around that?
As I briefly showed in my triage video, we have brought the optometrists outside. We have asked them not to touch the glasses and lenses, to reduce the contact. So when they receive the glasses, they clean with antiseptic, and then they do a lensometer so that you can quickly know the power of the glasses. The second thing is autoref is done. So they have a reading and they go for subjective correction. So they don't do a retinoscopy unless it's really mandated in complex cases where the autoref is not reliable. Then they do a retinoscopy to know the refractory status. So these are some of the ways. So mainly is putting them outside the closed area and putting them in an area where there's well ventilated, and making sure whatever they go in close, the trial lenses or frames, to be kind of decontaminated with antiseptic solution after usage. That's
really useful, I think, because there's not a lot of places where refraction services aren't happening at the moment.
Exactly. So we have to seriously think of bringing them from a closed area, because that's the worry. Now, even if you have air conditioning, you have a flow, if they are inside a closed space, if the patient coughs in front of you, definitely by the time the air gets circulated, the risk for you is very high, even while wearing a mask.
So last question for now. Do you clean the plastic barriers between every patient? Or after every patient?
Only around the area where he's sitting, not the whole plastic barrier. At the end of the day, the whole plastic barrier in the conjunctivitis clinic is clean, because it's very difficult to access to all the areas. But what we do is every, like in the afternoon, there is a break time, we close the door and switch on that UV light for a couple of hours from 12 to 2 o'clock. And then evening from again 6 to 8 p.m. So we have put a UV light, and so that small area can be decontaminated, especially the plastic cabin. And then we keep it off 2 hours in the lunchtime and 2 hours in the evening time.
That's good practice. I'm just thinking more broadly for people who may not have the access to that. I guess there'd be a different kind of cleaning system that they might need, or to reconsider it.
It's very difficult, because it's very difficult for somebody to always spray something and keep cleaning. So only the area around the slit lamp, like that area they clean every hour with the Lysol or soap solution or whatever is safe. And then the slit lamp, chin dress, and everything is clean for every patient, because they are all conjunctivitis patients where you believe that COVID positivity may be high. Because at this point, we don't know whether they are positive or not, but the chance for them to be high.
So thank you so much, Benki. If you can hang on there may be some more questions. There's lots more questions, but I'm going to give Guan a chance to talk. And then we can return to these questions at the end if we have time. So I'd like to now introduce Guan Chonghong, who is a Senior Program Manager at Orbis. She has been overseeing the SIB Child Eye Health Program in Shaanxi, China for the last 5 years, or just over 5 years, and a big part of an epidemiology study collaborated with the Ministry of Health in China in 9 provinces. And prior to joining Orbis, Guan was a senior project officer at Fred Hollows Foundation, where she was responsible for the cataract surgical training program in collaboration with the Jiangxi Provincial Bureau for Health for 10 years. She's also participated in RAB survey led by Hans Limburg in 3 counties, and has extensive experience in the design, budget and management of surgical training programs, child eye health programs and research programs. So welcome, Guan. I'll hand over to you to start your presentation.
Thank you, Jude, for introduction. Hello, everyone. Thanks for the, thanks for this opportunity to share social media used in a child eye health in China, project in China. Since Breathing Chair project is a child eye health project, which collaborated with multi-sectors, including education, health, disabled people's federation at provincial, city, and county level in 19 project areas in Shanxi province, China, and also 4 international NGOs. The project encountered misunderstanding and low efficiency in information delivery in the beginning. Then we used the WeChat for the communication in the project. Compared to other communication tools, WeChat is more efficient for busy clinical professionals. WeChat is easy to learn to use. Most county partners did not use email or had no computer skills before the project. So we provided a training to them on how to use email and how to use WeChat in the project. But they learned much faster than in using WeChat. WeChat has the benefit from improved mobile communication quality, reduce the data fee and cheaper smartphones, while the phone calls are still not free. WeChat is user-friendly with features such as voice or text messages, voice or video calls, and can upload pictures. WeChat used in Chair project laid the foundation for better use WeChat for consultation during COVID-19 pandemic this year. WeChat served as a bridges in Chair project. It bridged eye care professional networks. It bridged eye care professionals and parents. It bridged eye care professionals and educators. It also bridged international NGOs and 19 partner hospitals. Firstly, WeChat bridged professional networks for child eye health. Many different WeChat groups were created to offer technical support and post-training mentoring to professionals trained through this project. The WeChat groups in this project included clinical groups. Country-level eye doctors, nurses, or optometrists got post-training supervision and new information shared in the groups by mentor at the tertiary hospital, which had also used as a platform for interactive discussion. The low vision group was used between trainees at secondary hospitals and the trainers in tertiary hospital. The functional vision assessment group was used between over 50 trainees in China and the trainer in UK. The special education groups was used between trainees at all levels in China and the trainers in US. The school screening and referral groups was used between school teachers or school physicians and hospital professionals. Every county have more than 1 subgroups for this purpose. The key informant groups was set up between village doctors, all rehabilitation workers, and hospital professionals. The second, WeChat served bridged eye care professional and parents. WeChat is handful for clinical staff to access. It connected eye care professionals and parents for inquiries, make appointments, make a case referral, and even consultation. Tertiary hospitals in China have a WeChat official account. By following with the official WeChat account, parents can make appointments with doctor they preferred, review examination results, make online payments through WeChat. Some hospitals posted medical staff's WeChat QR code in the OPD or in the ward for parents or patients to get connected with their doctors or nurse. Doctors and nurses can respond to the inquiries when they are free, so there will be no interruption like phone calls during surgery or when busy in the OPD. Some parents also referred other children with similar problems through the WeChat group. We use WeChat for eye health promotion, disseminated short videos about refractive error, eye injury prevention, or ROP to school teachers or parents, and then they further shared the videos in their WeChat groups or WeChat moments. Online services were provided by cross-sectoral professionals through WeChat. There are many small WeChat groups set up for this purpose, is with parents. For example, a small WeChat group consisting of such as a trainer from other countries and a local teacher trainee and an ophthalmologist from local hospital was set up to offer advice and support to parents of a boy who was blind. So this is a screenshot about Chinese-speaking trainer from US offer instructions to the mother on how to teach her son who was blind due to ROP to learn. And the thirdly, WeChat bridged eye care professionals and educators. In this project, mainstream school teachers or school physicians were trained by county hospitals to do initial screening. So WeChat was used as technical support for screening and making referral. Head teachers played a critical role in referring children to hospitals through their WeChat group with parents, and because they are trusted by parents. Special education teachers were trained by international trainers. So WeChat also used as a on-spot technical support to non-school children at home. Some WeChat groups are still active in technical support, although the project already closed. WeChat also helped in creating medical and educational model to provide service together to children with visual or multiple disabilities at their homes. And the teacher, trainee, or parents posted video messages or short videos about the child with disability to trainers or service providers through the family WeChat group. This screenshot is about two international trainers were discussing the trainee with the training organizer in Shanxi province. They use different language because WeChat has a translation function. And fourthly, the WeChat played a really important role for communication between international NGOs and local partners. As 4 international NGOs are from different countries, it is not easy to get to meet physically, but WeChat helped us with this issue. A WeChat group was set up among project coordinators from 4 international NGOs and from 19 project hospitals. We had regular WeChat voice call and monthly WeChat meetings through this WeChat, so information conveyed is more accurate and more effective. The impact of the WeChat to this child eye health project. First, the WeChat contributed to capacity building of cross-sectoral professionals for child eye health through continuous technical support to trainees from in Shanxi. This technology empowered local partners and families to work together for child eye health at the county and the community level because it's more time efficient. About 10 subgroups were created and functioned in each of 19 project areas across sectors. And the long-term collaborative relationship has been established through these subgroups. We suggested to dismiss some of WeChat group when we closed the project, but the local partner, they would like to continue to use these groups to receive new information from their trainer or for communication. And this value has been proved after the project closed. One of our international partners had no staff in China for the project, but they learned and liked to use the English version of WeChat for mentoring their trainee and the parents of children with disabilities in China. Our partners' communication skills improved through WeChat. It was the biggest challenge, then became a great achievement in the end. WeChat improved efficiency and effectiveness of project management. The responding time for information delivered through WeChat is much quicker compared to other communication tools. We also created and distributed questionnaire through WeChat and collected over 3,000 responses from local stakeholders and beneficiaries at all levels, including community, for the final evaluation just within 10 days. So it is, WeChat is used a lot in this child eye health project. That's all I want to share with you. Thank you for listening.
Thanks, Guan. That was really a really interesting presentation around the use of social media platforms to bring together groups of people that are working on eye care. And I know when we spoke earlier, you mentioned that those same networks have been being used during the COVID-19 crisis, and they were quick and easy communication channels for people. I think that, you know, it really demonstrates the power of these chat group networks in a time of crisis in being able to manage parents' expectations, teachers and other health professionals. And particularly, we've had a lot of questions around the eye care sector, and having a forum that allows people to talk to each other is really quite strong and needed in the time. Again, I'll encourage everyone to put their questions onto the Q&A. Did you see an uptake? I think you mentioned there was an uptake in using the channels during the COVID crisis?
Yes.
And what kind of support were people looking for over those channels?
Yeah, because during the COVID-19, the hospital closed, and only for emergency surgeries or emergency services. So like parents or some doctors at county level, they want to ask about, inquire about the disease of child to our ophthalmologist at the tertiary hospital. So even the hospital is closed, but our pediatric ophthalmologists in tertiary hospitals, they are still busy. And also our pediatric ophthalmologists, they started to use social media to do webinar among the eye care professional networks, which was involved in this project at the county level or city level. So, and a few weeks ago, I asked them about the pediatric ophthalmologist, whether they really want to use this WeChat group for consultation. Then they said yes, because they feel they are very proud because parents want to ask them or make appointment with them, and the particular during COVID-19, because they cannot come to a hospital. So they really didn't care much about just like bother them even at night or lunchtime, but they are very happy to use this social media.
We have one comment and question, a very interesting use of WeChat and fascinating, thank you. Is there any data on acceptability by different groups, such as the parents or the medical professionals, and any challenges faced by introducing WeChat as a way to communicate?
We don't have data for that, but yes, for parents, because during the project time, it is very active, because it saves time, and also because we encourage the referral uptake. So during that time, nurses also played an important role for getting connection with the family group. But I think after this project, the doctors, they become to use that, and they used more. And there were 2 pediatric ophthalmologists, they said that they were so busy. So when they were doing OPD or doing surgery, then after that OPD or surgery, then they have to they check their WeChat, because there are so many parents ask them. And one pediatric ophthalmologist, she was so proud to share something, screenshot on her WeChat moments. She said, I was so touched by a girl who is now 18 years old. And she thanked me a lot through WeChat, because I helped her to improve her vision, like as a strabismus and amblyopia, when she was only 5 years old. So maybe that's because of those things. So the ophthalmologists, they were so proud of use that. They use them more now. But during
to have to get that positive reinforcement, which encourages them to use it. I'm going to give one more question to Venki, and then we'll have to wrap up. But we've had a few questions, Venki, around community eye screening or outreach. Have you got plans on how you're going to restart, or innovations to sort of make community eye screening after lockdown return?
The community outreach is, even though it is conducted by us, throughout the country, it is governed by the government policies, by the National Program of Control of Blindness. So without their consent and concurrence, we cannot do any outreach activity. So at this point of time, there is a circular from the National Program of Control of Blindness that there won't be any outreach activities until they come back to us. So ICAMs are not going to be there. But we are slowly starting up our secondary and also primary care centers. So Pondicherry has got 12 centers, Aravind has got 85 centers. In the 12 centers, we were able to start 5 centers, because now they have zones, red, orange, and all these zones depending on cases and containment. So wherever it is safe, we have started, and we see a significant increase in the footfall in these vision centers. Normally where they're seeing 15, 20 patients, now they're seeing 30, 40 patients. So we have added one more manpower, and we are trying to do all the social distancing because there is a limited space there. But it looks like people are not, they don't want to travel at this point of time. So that's the inference we get at this point of time. But it's too early to say, because people are not able to go to hospital because public transport is not there. You have to have your own car or two-wheeler to come. So they are going more to those vision centers, or the primary eye care centers, which is under our domain and our control. But community outreach, until the government gives a go-ahead, we won't do it. But again, social distancing and all that in community outreach will be very difficult, because you have to bring them in the bus, 50, 60 patients. Then only all this will be cost effective for us. So we can't social distance them in a bus and bring them and send them back to the campsite. All this may not be practically possible at this point of time.
Yeah, something that's to be watched to see what happens in the next phase of the pandemic, I guess. Because it is a question we're hearing a lot, but I haven't heard anyone that has answers yet to that. So with that, I would like to thank very much our speakers today, Venki and Guan, for such informative, fantastic presentations and being so professional in your question and answers. We could talk all day. We have enough questions to talk for another hour, I think. So we might follow up in the future and see, check in with what innovations are still going and what you are doing new in going forward. Rach, if you wouldn't mind putting up the slide. We'd also like to thank our members and patrons for their ongoing support of IAPB, because without them, we wouldn't be able to put on the webinar series and most of the other good work that we do. As you know, this web series is a part of the COVID-19 and eye care support program that we're running, which includes the online resources, which we curate and update each week, and also has member stories, so you can see what other organisations in eye care are doing around eye care services at this time. So please visit our website with the address that's on the screen now, and you can also see in our web series we have coming up. We have the SIB Child and School Eye Health webinars. Now, they're not strictly COVID related. They are on the program as part of the SIB program, but I wanted to make sure you knew and could attend them if you would like. And as part of the COVID series, we have question and answers with the UN, Ambassador Aubrey Webson and Robert Skinner on the 9th of June. We have a follow-up question and answers with the WHO with Alakos and Silvio again. And we have some recorded webinars that are considerations for ageing and managing inequalities that will come throughout June as well. So to keep up to date with the program, please subscribe on the website. We also really value your feedback and appreciate what you have to say. At the end of the webinar, a survey link will be sent out. If you could take a few minutes just to fill out that survey, we would really appreciate it. And the recording link will be sent to you in the next few days for this webinar, and you'll find the other webinars on the YouTube channel as well. So I would like to thank you all for your time today, and thank you to Venki and Guan, and look forward to seeing you online next time. Thank you, everybody.
Thank you, Jode, and thank you, IAPB.
Thank you, Venki. Thank you, Guan.
Thank you. Bye.
Bye, everybody.